So, as you may know, the majority of prostate cancers now being diagnosed are ending up on active surveillance. And there was a recent article that was written that talked about PSA prison, that a number of men who end up on active surveillance feel like they're in PSA prison because they feel like they're always, captive by their PSA and the psychological stress and anxiety that goes with that. There's a significant increase associated with men on active surveillance. And so, the option has only become available really as a result in the more recent years of the technological advances in genetic testing, imaging, and biopsy modalities. So we're very fortunate to be able to offer better active surveillance protocols that aren't as tortuous as they once were, with repetitive biopsy after biopsy after biopsy. So my question to Dr. Powell is, with your extensive expertise on racial disparities and associated genetic risk factors for disease and disease progression, what is the role for active surveillance for men of African descent?
I'm glad you asked that question. I'm writing a manuscript on that right now, in fact. But I want to make one statement about cookbook medicine. When we start talking about, if you have this, you get this, if you have this, you get that, we always get in trouble when we start doing that. Everybody's an individual. We're all different. And so what I'm doing now is looking at the genetics, particularly of men with a Gleason score of 6, or grade group 1, as we call them, and a grade group 2, men who have Gleason score 7, 3 plus 4, as we call low risk intermediates. Those are the men that we think some people think should be on active surveillance. And I agree. I have lots of patients on active surveillance who have a Gleason score of 6. Gleason score of 7, I am not recommending in my practice, and I'll tell you why, active surveillance. Now, what I've recognized doing a study using what we call, well, I won't go into the details because it gets too scientific. But within each of those grades or grade groups, there's heterogeneity. There's some people going to have a genetics that's going to say that they have a very aggressive cancer, and there are going to be some who don't, and both grade group 1 and grade group 2. And now with this methodology that we have, we can identify the heterogeneity. We can find men with Gleason score 6 that have the same genetic and biology as a person who has Gleason score 8, 9, and 10. They just have not presented what we call phenotypically with the clinical findings of a Gleason score 8, 9, and 10, but genetically and biologically, they have that potential. So we have to be able to identify this heterogeneity and place this person, and we're able to personalize and identify exactly the number of genes and the kind of genes they may have that's going to cause cancer to progress. I'm in the process, as I said, of writing that, so I don't want to go into too much detail, but that's what's important. It's not just one group. It's a group of people who have different potential to develop and progress.
And do you think we have enough available genetic data on the African American population that can actually help direct us adequately on active surveillance for these individuals?
Absolutely not. And the commercial genetic studies out there, as far as I'm concerned, are not very helpful. They weren't developed on prospective studies. They did not go through the rigorous statistical analysis that we have done in our data, where we have looked at the new statistical analysis of bioinformatics and looked at the network analysis, ingenuity and network analysis, where we can identify not only the number of genes that are drivers that cause the cancer, because a lot of genes, what we call passenger genes, they don't do very much of anything as far as function, but there's a very few that really are drivers, and also they interact with each other. And so that's the kind of analysis that we've done in our genetic studies, where we can identify the heterogeneity and the racial disparity. As I mentioned earlier, there are certain genes that are more expressed among African Americans that are associated with aggressive disease than among European Americans. So we published that recently in January in Urologic Oncology. That was published. So we're learning a lot, but there's a lot more to learn. But we have the only data looking at those specific issues. And one of the problems is many of the institutions that have the money, for example, University of Michigan has lots of money, a lot of researchers, but they don't see African American they don't see a large percentage of African Americans. With Harvard, with Johns Hopkins, all of those institutions have lots of money to do lots of research, but don't have the patients. So we don't have that large data set that you were asking about of African Americans and genetic and biological studies.
And hopefully we'll be able to address that better as we move forward with getting that data.
Yes.